Hi, my name is Hilary Alban. I'm a student of Universidad Católica Santiago Guayaquil, and today I'm going to share with you an interesting topic, which is glucocorticoid-induced osteoporosis. First, definition. Glucocorticoid-induced osteoporosis is the most common secondary cause of osteoporosis, and the resulting fractures cause significant morbidity. Following initiation of oral glucocorticoids, rapid bone loss occurs, and fracture risk increases within a few months in a dose-dependent manner.
Osteoporosis is a bone disease that causes more than 8.9 million broken bones worldwide across men and women every year, resulting in an osteoporotic bone break every 3 seconds. Osteoporosis is a medical condition that weakens bones and makes them more likely to break. They can become so fragile that in serious cases, a strong sneeze or minor bumps can cause them to break. Wondering why you haven't heard more about osteoporosis? Well, one reason could be that it is known as a silent disease because you can't see or feel bone loss, so it goes unnoticed until the first bone break occurs. Both men and women are at risk of osteoporosis. Postmenopausal women are at a higher risk. After an initial fracture, these women are 5 times more likely to suffer another bone break within a year. The World Health Organization, WHO, has considered osteoporosis to be of increasing importance. Many women remain untreated within 6 months after an osteoporosis-related fracture. It's important to be aware of the risk factors associated with osteoporosis in order to understand if you could be affected. Here are a few to consider. Previous bone break as an adult. Advanced age. Low bone mineral density. Parental history of hip fracture. Low body weight. Smoking. You've likely heard that vitamin D, calcium, and weight-bearing exercise can help keep bones healthy. It's true, but for people with osteoporosis, it may not be enough to protect against a fracture. Osteoporosis and broken bones are not a normal part of aging. If you are a postmenopausal woman, you may be at risk for osteoporosis.
Applications in medicine. Excessive amounts of systemic glucocorticoids leads to clinically significant adverse effects on the musculoskeletal system by inducing inappropriate bone remodeling through direct and indirect mechanisms and muscle atrophy that contributes to osteoporosis and fractures. Early bone loss is driven by changes in levels of estrogen and parathyroid hormone that stimulate receptor activator of nuclear factor Kb ligand, induce osteoclastogenesis. Osteocyte and osteoblast apoptosis prevents effective mechanosensing and new bone formation. Pros and cons. Pros. Patients who receive glucocorticoids should be counseled about adequate intake of calcium and vitamin D, weight-bearing exercise, and avoidance of smoking and excessive alcohol intake. The risk of fractures decreases rapidly when glucocorticoids are discontinued. Exposure to glucocorticoids should be minimized as much as possible. Bisphosphonates are recommended as first-line treatment of osteoporosis. Daily calcium and vitamin D supplements can help prevent loss of bone mass. Cons. Risk factors for glucocorticoid-induced fractures include age, like greater than 55 years, female sex, white race, and long-term use of prednisone, a dose of more than 7.5 milligrams per day. Pharmacologic treatment is strongly recommended for anyone who has had a fracture and for patients who are at least 4 years of age. According to the Fracstool, the risk of major osteoporotic fracture is 20% or higher, or the risk of hip fracture is at least 3%. Among patients who are receiving glucocorticoids and have a bone mineral density T-score of -2.5 or less, indicating osteoporosis.
So one of the big things from the conference that came out yesterday was the preliminary ACR guidelines on management of glucocorticoid-induced osteoporosis. It's been a while since we've had a guideline, since 2010, so it's time for an update. So I'll give you guys the highlights of the, and then at the end I'll give you my two cents on it. So they use the grade method for assessing quality of evidence, and it assigns it a letter grade in terms of how good the evidence is. So in terms of the recommendations, they recommend that for all age groups, the patients on glucocorticoid should have clinical fracture risk assessment. So assessing how much glucocorticoid dose they're on, how long you expect them to be on steroids for, risk of falls and frailty, etc. Second thing is that in adults over the age of 40 or more, you should do a baseline 10-year fracture risk assessment using a FRAX, and to do a bone density with the FRAX score as well. One highlight that came from the talk yesterday is that for FRAX, you can actually make an adjustment for glucocorticoid dose. So not everybody is going to be equal. So some patients on very high dose glucocorticoids is not going to have the same FRAX score as those on low dose. I did a Twitter post yesterday with
Issue play in Ecuador. In Ecuador, approximately 1 million women suffer from osteoporosis, with a prevalence in the postmenopausal population of 25%. The disease is estimated to cause 25,000 fractures each day. About 1 in 3 women and 1 in 5 men over 50 will experience an osteoporotic fracture in their lifetime. Conclusion: osteoporosis is common in patients requiring a long-term treatment with glucocorticoids. Careful attention to preventive management may minimize the severity of this serious complication. Thank you.